Um, okay, so my task was to defend the case for not weaning oxygen in children with ILD. And I always show this disclosure, but it's no big deal. And, you know, I knew this was a bad idea because you know, it seemed like I might have the advantage. Some might have thought that this was the easier side to defend, but obviously my worthy opponent, and especially after hearing her, she definitely has the advantage. And the reason for that is, true to her name, she's young, she's smarter than I am, and she does not practice medicine at 5,000 feet. So we all know that children's interstitial lung diseases are a group of diverse group of rare lung disorders associated with diffuse changes on X-rays and often associated with low oxygen levels. And this study, which is widely quoted, I'm going to call this Dr. Young's study because she's the second author on this paper. And I have to confess that, yes, I am an author on this paper, but I'm one of those et als way down the list. So one can see that the most common sign or symptom in patients in the study was hypoxia or hypoxemia, and virtually every patient in this study in which it was tested or recorded had this finding. And therefore, we have the British Thoracic Guidelines for Home O2 Use in Children, and they clearly state that long-term oxygen therapy, or LTOT, should be offered to hypoxic children with interstitial lung disease who are otherwise ready for hospital discharge. So they were looking at it from a hospitalized patient's point of view, and the same position was held for patients with obliterative bronchiolitis or bronchiolitis obliterans. And the reason why this is recommended, and this is, you know, I did such a good job of training Tim that he basically stole all my thunder. So I'll have to, you know, go over this, but you've heard this before. So hypoxemia causes pulmonary hypertension, but the precise severity and duration of hypoxemia needed to do this are not known. The factors affecting individual susceptibilities are also unknown. And this is the BTS statement that saturations greater than 94 to 95% appear to reduce pulmonary hypertension, while levels less than 88 to 90% may cause pulmonary hypertension. And this doesn't apply to patients with congenital heart disease or idiopathic pulmonary hypertension. Now, this is what is considered to be expert opinion. So when you do these guidelines, you have to weight the evidence and, you know, to give it credibility. And so there's very little objective data that actually supports these statements. So this is more like consensus or expert opinion, I have to say. And as Dr. Vesey pointed out, the way that low oxygen saturations cause pulmonary hypertension is that low oxygen levels cause the pulmonary arteries, which are normal here, to constrict. And then the right ventricle, which has to pump the blood through those vessels into the lungs, has to work a lot harder to push the blood through those tight vessels. And the net result is that the pressure goes up. And this is not a good situation. And again, in Dr. Young's study, you know, almost half the patients tested had evidence of pulmonary hypertension. So again, common to have hypoxia and common to have the consequence of hypoxia, which is pulmonary hypertension. And this is a severity of illness score that I developed many years ago. It's a very simple scoring system. It seemed to be the way that I thought about patients. So the number one is that the patient has no symptoms and no hypoxemia. Number two is the patient has symptoms. Number three is there's desaturation only at night or with exercise. Number 4 is O2 desaturation all the time. And then 5 is the patient has pulmonary hypertension. And I have done studies to show that the score affects outcome. So the patients with the higher scores, particularly number 5, in the large series of ILD patients, did not do as well as the patients that had the lower scores. Now, the other consequences of chronic low oxygen saturation, which have also been mentioned, are and so I just emphasized the parts in red. Hypoxia may have adverse effects on cognition and behavior, and may be associated with suboptimal growth. So those are the two things that have already been alluded to. And to steal a page from my colleague, Ann Halbauer, who's a sleep expert, she has done very elegant studies to show that patients with obstructive sleep apnea, which is a completely different kind of problem, have impaired neurocognitive function that improves when the obstructed breathing and the low O2 sats are corrected. So one could argue maybe that it's the obstructed breathing that leads to these consequences, but I would argue that the low O2 sats have a lot to do with it. And then with regard to poor growth, again in Dr. Young's study, a considerable number of patients had failure to thrive, and I believe that hypoxia also had a lot to do with that. Okay, so this is what we know about low SATs in BPD patients. Actually, there was a study done a long time ago. It was done in Salt Lake City. So Salt Lake City has the same problem that Denver has. They're both at 5,000 feet. So these were patients with BPD, chronic lung disease related to prematurity, and this was a prospective study where the patients were getting ready to be weaned off of oxygen, and they did an O2 sat study overnight, and they had two groups of patients that they decided to wean. One group had a room air saturation during sleep of 88 to 91%, and the other group had a O2 saturation greater than 92%. So prior to this time when they were on the oxygen, their average weight gain was, in the group 1 was 15.9 grams per kilo per day, and group 2 a little bit higher. But then they weaned them off of oxygen, and after that, the group 1 patients had a much slower rate of growth, 3.7 grams per kilo per day, compared to group 2. And so therefore, that implies that low oxygen levels may indeed affect growth in patients with chronic lung disease. Interestingly, also, they did another part of their study is they monitored the room air saturation of these patients for 20 minutes in the clinic, and then they did the studies at night in room air. And so the point of this slide or this study was that the O2 saturation in the clinic had no predictive value as to what the O2 saturations were going to be at night. And so just screening patients in the clinic doesn't work. And so just to emphasize that, the SATs were all what we would consider to be in a reasonable range, greater than 90% in the clinic. And yet there were patients down here who had a low saturation during sleep, even though their O2 saturation in the clinic was okay. Does that kind of make sense? So therefore, just having a random saturation in the clinic or during the daytime does not predict nighttime desaturation. And I think that one needs to be careful about that. Okay, there was another study in patients with severe BPD that showed that these patients, not surprisingly, had lower saturations during feedings and higher rates of growth delay. So I guess one question that keeps coming up is, what is the minimal SAT that will prevent these complications? And the answer is, we don't know. So So the party line, I think, generally is we would like to see the average saturations, as Dr. Vesey said, raised higher if they are in the 80s. And I personally would be happy with 90 or better. Some people would say 92. And the truth is, we don't know. So this is kind of expert opinion. But I think that 90 is actually adequate. And the question that was raised, is the oxygen delivered by nasal cannula safe? At least if you're not a preterm child, where there's no more risk to your eyes to get in this retinopathy of prematurity. So the real risk is if you breathe a high enough concentration of oxygen, say 60% or higher, as was shown, then yes, this can damage your lungs, and we use this for animal models to study lung injury. So this is a study that I did many years ago, and I can tell you how I did it, but it doesn't matter. And it really looked at the oxygen cannula flow versus the inspired oxygen concentration, because don't we really want to know that when you're giving a half a liter of oxygen, how much oxygen is that actually? So I divided the patients into preterms, those that were less than 3,500 grams, and a term or slightly older, but these were all in the nursery, greater than 3,500 grams. And one can see that in the smaller babies, actually a small increase in a low liter flow, raises their FiO2 quite a bit, and they could get up to 40%. Even on maybe a half a liter or so. But in older kids, even at 2 liters, really, this one patient never got above 35%. So why is that? It is because when you deliver the oxygen by nasal cannula at a low flow, it depends on really how fast and how deep the patient takes in a breath. And that we would call that inspiratory flow rate. So in a neonate who breathes very shallowly, whose inspiratory flow rate is not very high, breathing a little oxygen, there's not enough flow to entrain room air around that oxygen to dilute it down, to bring it down. But in older children, their inspiratory flow rates are much higher, so when they take in a breath, they pull in a lot of room air around that oxygen and they dilute it down. So I don't think that one can deliver a high enough oxygen concentration by nasal cannula in the flow rates that we use to really be worried about damage to the lungs. I guess that's the point. So who do we wean? So, we're not really arguing this point because obviously there are patients that we would, want to wean and would like to wean. And so in this simple scheme, it's related to disease severity over time. So if you start out at that end and you're in oxygen, then you have 3 possible scenarios. And it's not a straight line, but you can get worse, you can stay the same, or you can get better. So the patients that get better are the ones that are candidates for weaning, but I would submit that these two, the patients following these 2 lines are not the ones that you want to try to wean. So when to wean? So, I would say if the O2 sats are consistently above 90%, and that, and that includes the dips into the 80s, I don't think that matters much as long as the average is above 90 or better. If the patients are gaining weight well, and there's no evidence of pulmonary hypertension, I think that these are patients that are good candidates to be weaned. And then there's this situation, which is actually people have come up to me at this meeting and asked me this. So what do you do when the patients actually feel better on oxygen, but they actually have SATs that we would consider acceptable? And there are patients that are like that. So to me, that question means, are they sort of used to the oxygen, or it's a psychological thing that they need the oxygen, or does it really make them feel better? And I actually don't know the answer to the question, and I struggle with how to advise patients, but I tend to be liberal with the oxygen, so if it makes them feel better and it's not dangerous, I would say, okay, it's okay to try it. So in summary, my argument is simple. Patients with child often have hypoxemia. Hypoxemia has serious consequences. Oxygen should be used to prevent these consequences. Oxygen delivered by low-flow nasal cannula appears to be safe, and patients should not be weaned unless they are clearly getting better. Thank you very much.